Good morning in Latin America and the United States. Good afternoon in Europe, in Bristol, and good evening in Asia. Welcome to the final session of our international seminar, Disease, Illness, Sickness, Philosophical Perspective, held by the Universidad Nacional de Educación a Distancia, UNED, in Spain, and the University of Antioquia in Colombia. I'm very happy to share with you today. My colleague Agatha back from the UNED is going to present to introduce you our special guest today, Professor Havi Carel. Thank you to be with us. Agatha, good morning.
Well, good afternoon here, actually. Hello, everyone. It is my real pleasure to introduce our today's guest. This is also the closing session of our seminar that lasted for 10 long months, and we were happy to bring together scholars from Latin America, Europe, and the States to talk about philosophical perspectives and dimensions of illness. And it is so great to have with us today someone who inspired many of you and many of our students, Professor Havi Carel from University of Bristol. I know I don't have to introduce her too much, but we know that she works on the problem of illness from phenomenological perspective, and her two books, Illness and Phenomenology of Illness, had a big impact, I believe, on philosophy in Europe and Latin America. What else can I say? Maybe about the topic that the epistemic injustice in healthcare is something that Professor Carel is interested right now, research-wise, and that she is the main researcher on the Wellcome grant that is devoted precisely to research on epistemic injustice in healthcare. The concept that she herself and other researcher Keith coined and adapted to the field of medical sciences and healthcare sciences. And it's a real pleasure, Havi, to have you with us today. The session, just a few words about the session. It will be held in English. Professor Carel has 40 generous minutes to speak. We won't stop you at any point. So just feel free to share the conference at your pace. And yes, after that, we will be having a session of questions and answers, and you are welcome to make questions in English. If you need to say that in Spanish because you feel more comfortable with that, we can translate. Yeah. So that will be all on my part, and well, welcome, Havi.
Thank you very much, Agatha and Andres. I'm delighted. I should first of all apologize that I can't speak to you in Spanish, because actually my mother is from Chile, but unfortunately she never taught me Spanish, which I'm very regretful about. So I know it's a beautiful language, and I'm just sorry I can't connect with everybody in your own language. So I hope it will work okay in English. And yeah, as Agatha said, feel free to ask in Spanish or put your questions and comments in the chat in either language. Okay, so I think I'll try to share my screen first of all. One participant can share. Hang on. Share. Here we go. So now, this is the point at which things go wrong. There we go. So hopefully you can see me and the screen.
Perfect. Yes, we
Cool.
see
Okay, great. Yeah, so I started working on epistemic injustice exactly 10 years ago. And I should say that a lot of this work I did collaboratively with Ian James Kidd from the University of Nottingham. And so all of our publications, or almost all of the publications on epistemic injustice, are either Carel and Kidd or Kidd and Carel. And also to say that I'm very happy to send PDFs of papers. If any of you after the talk think, oh, I'm interested in this point or that point, please drop me an email and I'll happily share PDFs of the papers. We try to make as many of them as possible freely available online, but if not, I can send a PDF or point you to where the paper is. So there is a growing literature on epistemic injustice, and it's been very productive, and it's been very creative in the sense that people have offered a lot of amendments to this idea of epistemic injustice, and suggested borderline cases or cases that intuitively should count as cases of epistemic injustice. And so the concept itself is still under construction, if you like. So the philosopher Miranda Fricker offered it in her 2007 book, Epistemic Injustice. And lots of people have since tried to offer other kinds of epistemic injustice in addition to the ones Miranda offers in her book. And she herself has revised and thought through some of her concepts. And then people went on to suggest other kinds, participatory injustice and epistemic appropriation, and willful hermeneutical ignorance. Lots and lots of concepts have been added to the toolkit of epistemic injustice studies. So this isn't really a talk about a specific concept, but it's an attempt to suggest some of the reasons why epistemic injustice as a concept is particularly important within healthcare, and to give maybe a general idea of why what epistemic injustice in healthcare looks like. So that's the plan for the talk. And I also want to say a few things about vulnerability and its connection to epistemic injustice. Now, this work is not disconnected entirely from the work Agatha mentioned a minute ago, that of phenomenology of illness. I've been living as a person with a chronic lung condition, and I have been writing about and trying to use phenomenological concepts and tools to understand and study the experience of illness. And at the same time also suggest that it's not just that we can harness phenomenology and use it to study illness, but also that we can think about illness as really having a very significant place within phenomenology, within the area of philosophy that aims, if you like, to study the experiences of the self. And that's for the following reason. The reason is that illness is a fundamental life experience. It's a fundamental aspect of human existence as embodied, vulnerable, fragile, physiological, if you like, or biological entity that we are. And so I don't see this as disconnected from my previous work. In the previous work, I tried to spell out what a phenomenology of illness is and what it should look like. And now I think of epistemic injustice as very much an extension of that work, primarily because one thing phenomenology does really well, it gives us the tools with which to reflect and discern and also articulate and share our experiences of illness in a way that actually can serve as an antidote to epistemic injustice, or to situations where people are unable or only partially able to speak about their illness experiences. The long word that you see on the screen, lymphangioliomyomatosis, is actually the very unfortunate name of my own respiratory condition. And I like to use it as an example of how medical systems, medical traditions, and medical bureaucracies can really alienate people. So I remember the first time somebody says to me, a doctor said to me, this is what you have. It's called lymphangioliomyomatosis. And my first thought was like, you've got to be kidding me, right? But it's not. This is the official name of the disease. It's actually shortened to LAM, L-A-M. And I think in many respects, what I also want to do is to move us away from thinking about illness as some sort of aberration or break or something that is entirely divorced from our other experiences, and to try and think of illness, if you like, identities, narratives, stories, accounts, as being very much of a piece with the rest of our life. So we can think of the way in which we become ill as related to other types of bodily vulnerability, aging, disability, congenital conditions we're born with. And then to also think of other areas of adversity in our life, trauma, heartache, heartbreak, political unrest, famine, war. Think of all of those as things that, again, are of a piece. So I want to, towards the end of the talk a little bit more about this idea of vulnerability, and to say we are all vulnerable in one sense of the word, but in another sense, some people are more vulnerable than others, and that's because of their particular position within healthcare systems, for example, within state bureaucracies, and so on. So I'll start with a few quotes. This is from a woman who's just recently given birth. And here's what she says. I had acute epigastric pain going through to the back during the night, but got no relief. It was implied that it was anxiety, and diazepam was prescribed with no effect. It seemed to me that in view of the massive and rapid changes in my body, a physical cause was quite likely. I felt the interest in me had waned and there was less understanding. No one took the pain seriously. And another quote, this is from interviewees who are psychiatric patients interviewed by Bigging and Ridley. I feel like I'm howling at the moon. No matter how coherent, how rational, how considered my arguments and my explanations for events are, that assumed level of incompetence undermines it because you're given sub-status. Getting shouted at, getting called a retard, getting called a bastard by staff here, and nothing's ever done about it. Management just says, oh, away you go, you know, you're imagining things. But we're not stupid. We may have mental health problems, but we're definitely not stupid. The third example, this is a woman from a patient group, online patient group of respiratory conditions. I don't mention problems, she says, because though they're real for me, they're minor in the grand scheme of things. So here we're seeing something slightly different. Here we're seeing somebody who says, I don't even try to speak up because I don't want to take up too much space. I don't want to be seen as a complainer or somebody who demands more than their share of medical attention. And the final one, a woman writes, I had an abnormal cervical smear, so was sent for a coloscopy. I changed into the usual ties up the back gown with the usual vital ties missing, and then went through for the examination. Lots of big sighs from the consultant with his head between my legs. Then off he goes, leaving the room. I'm told to follow. So I arrive, naked under a gown which doesn't do up, slightly damp between the legs, and a bit stressed, as I have to sit down and I'm worried about leaving a wet patch. He goes on to tell me I need an operation. I hear blah, blah, blah as I'm perching and panicky, and it's very difficult to think without your pants on. I said nothing. So let's see what is actually going on when patients say these things. And these things, I'm sure those of you who have looked into the types of things that patients say about their care and patient complaints and patient feedback would say that these are not uncommon situations and complaints. And we look at these kinds of epistemic complaints that are found in abundance in healthcare, and we see that there are two broad types. There are patient complaints, patients saying, I'm not being listened to. People don't have time for me. I say stuff, but it's not taken seriously. I said I was in pain, but nobody offered me pain relief. And we also see there are physician complaints that run, if you like, in parallel, where physicians say things like, patients are confused, they don't remember stuff, they don't have medical training, so they don't know what is and is not clinically relevant. They make funny associations between medically impossible situations. I remember once a doctor said to me, oh, you know, patients, they say a load of nonsense. They say, oh, when I eat lettuce, my elbow hurts. So I just ignore completely what they are saying. Now, what we need to see is the way in which these two types of complaints dovetail and feed into each other and mean that to an extent, patients and health professionals are embroiled in a vicious circle of epistemic problems. There could be misunderstandings, it could be the relative time poverty where people are in a rush and they don't have time to sit and have a proper conversation. And it could be just basic communication problems that happen between two people who are talking under a situation of stress and duress and time pressure, and they don't really know each other. And it's very hard to communicate well in that kind of situation. What happens in this vicious circle is that these kinds of complaints and problems both complicate and compromise epistemic relationships. So in an ideal world, the health professional and the patient work together to try and make epistemic gains, right? To understand what the nature of the problem is, to make a correct diagnosis, to consider rationally treatment options, and then to pursue a treatment and comply with it in order to achieve the best clinical outcome for the patient. But in every step of this process, we see that epistemic relationships that are dysfunctional or suboptimal will both complicate and compromise the quality of care. Another interesting feature is that these kinds of complaints are not new and they hold stable over time. So these are the kinds of complaints that you could find patients expressing 50 years ago, 30 years ago, and still continue to express today. And that points to the fact that this is a systematic and entrenched feature of healthcare, and not, if you like, a particular bug that affects this hospital or that clinic or this doctor or this patient. And I will also say that these complaints that point us to, let's say, epistemic disrespect or a downgrading of patients' offerings, epistemic offerings or testimonies, is particularly acute in certain areas in medicine. For example, in psychiatric care, in geriatrics, where people are elderly, in pediatrics, where the patients are children and are often not listened to and ignored, and possibly in other areas of medicine. These are the ones that I think are particularly interesting: psychiatry, geriatrics, pediatrics. So what do these epistemic complaints tell us? One way of understanding them, I'm not saying this is the only way, but this is certainly one way to understand them, is as reflecting one type or more of epistemic injustice. And these epistemic injustices arise when we have negative stereotypes of ill persons. So for example, when we say, oh, you know, sick people are very distressed, they can't think straight. or when we say, oh, this patient, they've been lying there for a week, they don't even have a good sense of, you know, of time, or when they last took their tablets, or how their medication is working. There might be other stereotypes and stigmas we have about ill persons, that they're too emotional, that they lack the medical expertise required to make sense of their situation, that they are forgetful, that they can't think rationally because of their distress. And we need to be particularly watchful and think about these negative stereotypes and the prejudices that produce them in the context of illness, where people are, they're not just, it is not just the stereotype that they are weak and unwell, they really are weak and unwell. And so I think there is a particularly significant epistemic obligation to communicate well and to listen and uphold the testimonies, beliefs, desires, and goals of patients. So if you like, it might be that health professionals have a particular duty in these cases to both guard against the negative stereotypes, but also to appreciate the vulnerable position in which patients are placed when they are unwell. And anyone, you don't have to have had experience of severe illness. It's enough if you remember the last time you had a toothache or terrible flu and how absolutely incapacitated that has made you. Importantly, an epistemic injustice is a specific type of injustice that is done to somebody as, if you like, a knower, or more broadly, an epistemic agent. So recall the woman in the first quote, she said, "I am in pain, help me." And she said, people just ignored me. Okay, so that's an injustice obviously done to her as a person and as a patient, but also as an epistemic agent. She made a claim, an epistemic offering, and it was ignored. Now, epistemic injustice, of course, has the primary epistemic harm of having somebody's testimony disbelieved or downgraded or ignored. And I would say this could be particularly acute when we're talking about rare diseases or diseases that are called contentious diseases, such as chronic fatigue syndrome, where the diagnosis can often be delayed and where symptoms are often confused with other diagnoses. There's misdiagnoses. And there is also the issue of some patients being maybe thought of or accused of being malingerers, of people who are making up stuff about their illness. So there is the primary harm, which is an epistemic harm, but it's also a there could be also secondary non-epistemic or much broader types of harm. So if somebody isn't listened to, it might be that the treatment they get is less appropriate. It might be that their social care needs aren't met. It might be that their benefits don't come on time because people are ignoring their requests, and so on. So epistemic injustice has a cumulative negative effect on both the clinical care of the patient, on their overall health beyond the specific issue for which they are, say, hospitalized, and also an impact on their social confidence and their lived experience. Are they going to be more or less likely to voice a complaint or a need next time? And of course, we don't just want to explain our medical needs when we are in medical care in hospital, for example. We also want to be met with both understanding and compassion. And there is an element in which good communication and good epistemic exchanges, of course, are crucial for understanding and compassion. So I want to now look a little bit more closely at two types of epistemic injustice. These are the two types that Miranda Fricker identified in her book, Testimonial and Hermeneutical Injustice. And as I said, there are many other types of injustice that we could also look at, but I'm going to focus on these two here. So testimonial injustice occurs where negative stereotypes of the sort I was just talking about introduce prejudices that in turn cause a credibility deficit. So I am a patient and I say, I've got a terrible stomach ache. And the health professional listening to me says, well, you know, she's a woman, she's a bit hysterical. She just had these painkillers. We need to wait a little bit longer. Or I'm about to finish my shift, so I'll just let the next person who comes on shift take care of this. So there are many ways in which credibility deficits can occur through the negative stereotypes associated with, say, being a woman patient or a psychiatric patient and so on. And the injustice stems from the fact that this credibility deficit undermines the testifier. I say, I am in pain, and nobody takes that statement seriously. Sometimes it might be that nobody can hear me. For example, if I am very frail and I'm lying in bed and I'm mumbling and nobody leans close in to hear what I'm saying, then that's one way in which I might be ignored. But I might actually be shouting, and the health professional might say, I'm not going to help you until you stop shouting. Another thing that could happen is I would say, I am in pain, and the health professional will say, yeah, I heard you, but you know, let's not get carried away. It can't be that bad. Let's give it an hour and see if you feel better. So there's different ways in which the injustice can take place, in which the testifier can be undermined. The injustice can be both incidental or systematic. So it might be that, you know, an educated white male person, you know, is in a particular context, gets a particularly unfriendly, hostile health professional, and they end up with a credibility deficit. And in those cases, we might say, well, maybe we would call this an incidental testimonial injustice. But there can also be systematic cases, which are, I think, more common, when somebody's characteristics mean that the negative stereotypes associated with being a woman or from a particular ethnic group with particular sexuality, age, and so on, tracks them throughout different encounters, through different interactions. So it doesn't just happen once. Usually, if somebody's credibility is downgraded and they suffer a credibility deficit and they are undermined as a speaker or a testifier, it is not an isolated incident. And these are what we call tracker prejudices. So people who are routinely prejudiced against people, we can see that the prejudice will track the person in healthcare, but also maybe in education, in housing, in employment, in the criminal justice system, and so on. So there are three ways that ill persons can suffer testimonial injustice, at least three ways. So one is the derogation I described. There are negative identity prejudicial stereotypes that are directed at the person and their credibility is diminished. But other thing can happen as well. We can also, in the specific case of illness, presume that they are completely dominated by their illness and therefore unable to make rational decisions, for example. Or we can also find the downgrading of testimonies that ordinarily we would take to be reliable indicators of their rationality, coherence, and so on. So we would say something like, oh, she's not usually that lucid, or we caught her on a good day. Here's a historical example taken from David Wooten. He's talking here about the discovery of nitrous oxide and of the time lag between when it was discovered to when it was put to use in medicine as an anesthetic. You need to imagine what it was like to become so accustomed to the screams of patients that they seemed perfectly natural and normal, so accustomed to them that you could read with interest about nitrous oxide, could go to a fairground and try it out, and never imagine that it might have practical applications. So this is a situation where the screams of the patients who are undergoing, for example, a limb amputation, have become transparent or inaudible to the health professionals, to the surgeons amputating the limbs. Another example from Dan Dennett. In the 1940s, some doctors fell under the misapprehension that curare was a general anesthetic, and they administered it as such for major surgery. The patients were, of course, quiet under the knife, but when the effects of the curare wore off, complained bitterly of having been completely conscious and in excruciating pain. The doctors did not believe them. Eventually, a doctor bravely committed to an elaborate test under curare, and his detailed confirmation of his subject's reports was believed by his colleagues. So this is an outline of what testimonial injustice might look like. So now we need to ask, what would testimonial justice look like? So we could say that we can give some characteristics of what a testimonially just health professional is. We could say that this is somebody who's alert to their own vulnerability to epistemic injustice, that they are aware of the fact that they might be committing an epistemic injustice against a patient, maybe a colleague who is lower down in the hierarchy, maybe a trainee medical person or a new nurse, and are therefore active in scrutinizing their credibility judgments, excuse me, and active in recognizing, soliciting, and including prejudicially downgraded testimonies. So these are health professionals who would go looking for the testimonies that were previously ignored or downgraded. Okay, I'll now turn to hermeneutical injustice, but I'll do this one a bit more quickly so we have plenty of time for discussion. So hermeneutical injustice occurs when a gap in our collective interpretative or hermeneutical resources puts a person or a group at a disadvantage when they attempt to understand their experiences. So what we have here is a situation where people are offering not a testimony, not saying I am in pain, but they're offering an interpretation of one of their experiences. So the example that Miranda gives in her book is that of the term sexual harassment. And she says, imagine the women who were around in the 1950s and 60s, before we had the terminology, before we recognized the concept of sexual harassment, and how they were trying to describe some of the experiences they had, say, in the workplace, but not really having the language, the concepts, the interpretative resources with which to talk about those experiences. And what this causes, Miranda thinks, is it leads to hermeneutical marginalization. So the woman said, oh, I don't like how my boss was touching me or looking at me or talking to me. And her friend says to her, her male friend says to her, come on, don't be so sensitive. Why do you always have to make a fuss? Why are you exaggerating stuff? Oh, just, don't be so sensitive. So this could be hermeneutical marginalization, where I offer an interpretation, but people are simply deaf to it, ignore it. And also social subordination. So the women who are trying to articulate their experiences of being sexually harassed, but don't have the language to do that, will possibly, one possible outcome of this is that they would submit to the unwanted attentions of the boss and just accept it as, oh, this is just how things are in the workplace, for example. Now, importantly, obviously, the hermeneutical resources are collective, not individual. I can't single-handedly start talking about a new kind of concept or experience unless other people buy into it and say, oh, that's interesting. Explain to me, how are you thinking about this point? So hermeneutical injustice is structural and not agential. It is not just something one individual person or agent might do. It is something that is intrinsic to a particular structure of a society. It has to do with power structures, the marginalization of certain groups, and the relative privilege, if you like, hermeneutical privilege of other groups. And hermeneutical justice, sorry, before I move on, arises because we have particular strategies of exclusion. You know, for example, we say, yes, we hear what you're saying, but I'm the one who writes the policy, behavior policy for the university, or only this committee can make decisions about how we treat our students, or I'm the boss in this workplace, so I am the one declaring that it's okay for the boss to touch employees in a particular way. So there could be strategies of exclusion where people are trying to articulate their perspective on things, but are just prevented, for example, from attending the committee meetings or from writing the policy document. And there are also cases where we say, oh, yes, you can speak, but not taking that tone, or you can participate in the meeting, but not using that language. Now, the result of this is that non-dominant resources that are being offered by non-dominant group members end up being marginalized and dismissed by the people who have more authority, if you like, within the group. So again, thinking about what a health professional who is hermeneutically just might be. So they are alert to the possibility that there are experiences that we don't have good ways of articulating, that there could be gaps in the interpretative resources, that these gaps can have a different impact on different groups. So the lack of the concept of sexual harassment probably worked in favor of the imaginary boss I was describing to you. And maybe he was quite pleased with the status quo, and maybe he and his friends did their utmost to ensure that women don't have a chance to sit together and think of how they want to articulate their experiences, or about coining the term sexual harassment. A hermeneutically just health professional is also aware of their own hermeneutic advantage. When a health professional, especially a doctor or a senior doctor, speaks, other people listen. Their interpretation or their understanding of, say, this medical case is usually accepted without argument. And they also think about whether they are employing, whether consciously or unconsciously, these strategies of exclusion and repression that I talked about. They're also aware of the hermeneutical difficulties that particular groups within our society have. So, for example, asylum seekers, refugees, can they speak up? Are their experiences routinely taken up and understood by the rest of society? I don't think so. And the hermeneutically just health professional will take account of all this and then adjust their conduct accordingly. Okay, I want to finish by talking about vulnerability. Because I think one thing that is important to me is to understand that there is this duality, if you like, between two understandings of vulnerability. One is this idea of shared vulnerability. So we're all universally, in virtue of being, if you like, biological organisms, in virtue of being human, share important vulnerabilities. So we all die in the end. We're all susceptible to illness. We're all capable of experiencing and probably have experienced some degree of pain. The same goes for psychological pain or, heartache. So we can think of vulnerability as a fundamental feature of human existence in general, and if you like, a universal or shared feature. But there are also particular social, economic, legal, and political conditions that make some persons more vulnerable. And we can think in parallel about the vulnerabilizing effects that make some people more vulnerable than others. So illness is certainly an example, but also disability, sexism, ageism, racism, ableism, and other forms of social injustice mean that, yes, we all share the important vulnerabilities I enumerated a minute ago, but also some of us become more vulnerable and are subject to the threat of being even further vulnerabilized because of prejudice and ill treatment based on the fact that they are of a particular sex, age, race, and they are ill or disabled, and so on. Now, vulnerability, of course, is not something we choose. And even though it's not something we choose, this is something I've said in the past about illness, because illness is also something we don't choose. Becoming vulnerabilized or being vulnerable or recognizing that vulnerability can also transform us. So it might be that we want to think about the edifying powers of illness, the moral and existential lessons that might become available to us through illness. We might think about the reflective coping that adversity demands. So when things become difficult, we reflect on what's happening to us. We figure out how to cope with it, not just practically, also emotionally, if you like, and existentially and morally. Or we can also think about what Jonathan Haidt calls post-traumatic growth that is sometimes afforded by trauma. So those kinds of experiences of suffering, vulnerability and vulnerabilization, of course, is never chosen, and of course is a terrible thing, but is also, to an extent, something that has the power to help us grow personally and to become edified. So the picture I'm suggesting here is that despite the sharedness of vulnerability, it's also unevenly distributed. And this increased vulnerability of some people on the basis, again, of age or illness or disability or race and so on, can give rise to social and other kinds of injustice. So vulnerability is both shared as a feature of human existence, but it is also lived in highly specific ways. And I want us to hold on to both sides of this picture. Now, how do people become vulnerable beyond the universal vulnerability I pointed out above? They can become vulnerable through events and the actions of others. So people can have the rotten luck of being refugees or being subject to an oppressive regime that silences them and hurts them in a myriad of ways. And that vulnerability is preventable and avoidable. And of course, we as citizens of the world ought to militate against it wherever we see it. We can also, in particular, think about institutions as places where vulnerability is instigated and where people, especially those who have access to institutional power, can vulnerabilize others. So we can think about a sadistic healthcare professional, a person in education who is also a sexual predator. We can think about an uncaring or negligent judge. We can think about a social worker who isn't doing their job properly. And in all of these cases, the people who are meant to benefit from the services of these institutions can find themselves vulnerabilized by the very institutions that are purportedly set up to help them. So one example that happened in the US and the UK, I don't know if that's what happened in Spain as well during the pandemic. In the beginning, people who lived in care homes, who contracted COVID, were taken to hospital and then returned to the care home without, especially in the beginning when there wasn't sufficient testing, and brought COVID. So they would be taken to hospital because they felt unwell. They would contract COVID in hospital and then bring it back into the care home. And very many thousands of elderly people died in that way in the UK and in the US. And that's an example of vulnerabilization. This is an example of a preventable set of deaths that took place because the people in the care homes weren't appropriately protected. And in the UK, a lot of talk was about, well, you know, elderly people, they've lived a long time. You know, when you're in your 80s, what can you expect? It was almost taken as an acceptable price to pay during the pandemic. And there was also a lot of talk of saying, why should all of us sacrifice ourselves in lockdowns and so on for the sake of elderly people? So that's exactly the kind of vulnerabilization that Shelley Tremaine, for example, has written about. So who might be vulnerabilized people? Maybe people with learning disabilities, people who suffer from mental disorder, other disabilities, people who've had limited education, the victims of domestic violence, those with neurodevelopmental disorders, elderly people, very young people, and so on. These are all people who are especially vulnerable and can become more easily vulnerabilized by the actions of others. The reason I think this is important and is really of a piece with what I was saying about epistemic injustice is because these kinds of suffering and these kinds of harm are preventable. And we need to be able to identify and articulate the external features of a situation that are causing the vulnerability, rather than taking it to be intrinsic and essential. Okay, so the last thing I just want to quickly flag up is the research project I started a few months ago called Epistemic Injustice in Healthcare. That's the URL. If any of you want to join our mailing list, please do. You will find a link to do that on the homepage of the project, which is generously funded by Wellcome. And just to say thank you for listening. Sorry, this was a little bit longer than I intended. And I'd be really very happy to hear not just questions, also thoughts, comments, suggestions, contributions, and so on. Thank you very much.
Thank you. Thank you, Havi, for this talk. I think it was just perfect. You don't need to, you know, just limit to 40 minutes. And I think it was worth it so that you can explain some other consequences. So we have some time for discussion. Please let us know what time do you have to leave exactly. Okay, so that we won't be Yeah.
Okay. Yeah. The bus is delayed, so
Good.
we should be okay.
Well,
But can we just have 1 minute? I just want to grab a glass of water and just
of course,
Okay, if we
yes.
take 1 or 2 minutes. And then
Yes, no
start the
problem.
discussion.
Take
Okay,
your time, don't
great.
worry.
Perfect. Some hands. There are already some hands raised. So Daniela goes first, and then Robson. Okay.
Yes. Can you hear me well?
Perfectly well.
Awesome.
Don't worry.
Okay. Thank you so much for this wonderful talk. I have a comment and a half-baked question, so bear with me. The comment is that, yeah, well, it's true that Spanish is a beautiful language. Some people say that Chilean is almost not Spanish anymore, so I say that as a Chilean. It's a random comment. The question is, you mentioned that epistemic injustice emerged from negative stereotyping, right? But I was wondering, I think there is some extent in which some people would think of stereotyping as having actually a positive effect in clinical settings. It's a kind of bias mechanisms that helps you to sort of make quick decisions in certain sort of environments. So to some extent, if you're working with limited resources in clinical settings, you will always be, someone will always be wrong. You could make the case that some degree of epistemic injustice will always be, in place. It's almost to some extent unavoidable. So, I was just wondering whether you have any thoughts on that.
Yeah, thank you very much. I mean, there's a lot in what you say. That at least two things that I picked up are, one in saying sometimes stereotypes are helpful as sort of shortcuts. Is that what you meant? Okay.
Yes.
And the other is, well, that in situations of stress, communication is always going to be difficult. Yeah. So yeah, I think you're right. I mean, I guess you are right that there are shortcuts that people make. For example, if the patient is young, they're not going to say, oh, okay, the stomach ache is probably cancer, because it's very unlikely. It might be, but it's very unlikely. And there's been a lot written. I mean, there's a whole, I kind of think people who are training to be diagnosticians and clinicians should actually do a philosophy degree and study epistemology, because what basic tools you use in your decision making isn't sort of clearly articulated, right? So there's been lots of stuff. For example, the work of Daniel Kahneman and Gerd Gigerenzer and many others talking about decisions we make rationally, slow thinking, if you like, and then the quick, intuitive gut feelings we judgments we make about stuff. And I think the idea is that we should try and avoid the intuitive gut feeling stuff. But of course, sometimes that stuff could be very end up being correct. So what I think we need to do is, of course, push for more time and push for more resources to be put into healthcare so people can have more time. We're in the UK, we have elections coming up. 4th of July is our, big opportunity to make a change for a government that actually thinks healthcare is really important, even for people who can't afford private healthcare, or to supplement their NHS healthcare with other kinds of healthcare. So I think ultimately the way health systems are set up is not a fixed fact. It depends on, at least to an extent, on the political decision of how much resources to pour into public healthcare. So I think this is what I'm saying, that we need to think about the vulnerabilities that are avoidable, because I think we can think, okay, look, psychiatric care is on its knees. We need to put more resources into psychiatric care. There's no way a doctor who's looking after 100 patients is going to be able to give all of them the right attention. So what you're pointing to here is something really important, which is to say there can be system constraints that are not, it's not that individuals are being malicious or acting out of vice. It is because the system is set up in particular ways. And, you know, bureaucratic institutions can be very damaging and vindictive and target particular people, for example, poor people or people with learning disabilities and so on. So I think you're spot on in saying that, first of all, stereotypes are much more complicated than and worth exploring in great detail. And I should probably say that Ian James Kidd has this notion of pathophobia, where he talks about the kinds of prejudices and stereotypes and fears that are aroused in people when they encounter sick people. So we can think about the stereotypes. We can also think about the processes we have for decision making, and we can also think about the responsibility allocated to the systems and how they are set up rather than to individual actors within the systems. So I think those are all great points you've raised. Thank you.
Thank you very much, Danielle. We had Robson with some questions, and then Elena. Robson, are you there? What happened to Robson?
No, I'm here. Yeah.
Good.
Yeah, I put in the chat is more precisely. Thank you, Professor Carel, for a nice talk. Should I read? Oh, you may read, Agatha.
Yes, go ahead. Yeah, read them. Just...
You can read your questions by your own, Robson.
Okay. Yeah. So my first question relates to the scope of the impact of verbal and non-verbal practices that promote epistemic injustice and its related harms. Donna Fricker described primary and secondary harms associated with testimonial injustice. Among the secondary harm is the loss of confidence in persons' cognitive abilities. Do you think that epistemic injustice in healthcare can affect the structural level of human experience? What you term in your paper pathology as a phenological tool as radical changes in the corporeal basis or bodily basis of existential in Heidegger's sense. If so, would it be acceptable to suggest an impact of epistemic injustice, for example, at the level of background feelings? For instance, on body certainty or body confidence?
That's so interesting.
Oh, my dogs are barking.
He agrees. He also thinks it's interesting. Wow. I'll need to think about it. Would it be accepted to just an impact of epistemics? Certainly, in the case of epistemic confidence, yes, of course, right? We all can think of examples of kids who, you know, we knew or the impact on kids when adults tell them repeatedly that they're stupid, right? And certainly that would ultimately end up affecting your epistemic confidence. Could epistemic injustice have an effect on bodily certainty? I think, yeah, I mean, to the extent that body certainty and bodily doubt are subject to the kinds of, or affected by the kinds of social judgments that we make, again, we make about people's skin color, we make about people's gender and so on, then I think, yes, this is a really new connection. I never thought of it before. But I would say it's certainly worth a lot more thinking about these connections. So thanks very much for raising that. It's super interesting.
Thank you. And
you have 2 more questions, so please go.
question, third, but it's too much, I think. Yeah. The second relates to epistemic injustice in child patients. You and your collaborators presented three conditions that must be met in an adequate approach to childhood experience of illness. Children are enacted, they are situated, and they are in development. Considering the developmental aspect, children are not only undergoing rapid organic, bodily, and socio-psychological development, but they are also developing a very basic type of feeling, trust. Do you think and trust, not only episodic trust, but a kind of more basic trust, monadic trust? Do you think that epistemic injustice can have an impact on the development of children's basic trust? If so, how do you envision the possibility of empirically and systematically research or investigating this process on the dimension of background feelings?
Yeah, absolutely. Absolutely correct. I mean, of course, the background trust can be completely destroyed. I mean, this would be very, very gross or clear cases of, for example, of childhood abuse and neglect, where exactly what is being eroded is the background capacity for trust. So I think you can see that in all situations where development is done against a background of deprivation or of violence, that is precisely the outcome. I mean, what's interesting and what's particularly tragic about children is that the effects are permanent. So if you if you don't give young children the minimal environment that's needed for the development, then some of these capacities will just not be restored. So, in cases of neglect, for example, you find children who then are unable, both as children and later on as adults, to relate intersubjectively with others, cannot make attachments or cannot create connections. So, I guess my slight niggle here is that I wouldn't say it's an epistemic injustice. I would say it's a much broader injustice, right? Basically, these people are being abused or neglected, and that, of course, has an epistemic dimension to it, but it wouldn't be maybe exclusively an epistemic injustice. But yeah, thank you very much for both of these comments. They're really, really interesting. Thank you.
Thank you, Robson. There's a third question in the background, but first, Elena, please.
Thanks so much. Very interesting talk, and I got so many insights. So really thanks. And at the very end of your talk, you mentioned an idea of how we can get rid of epistemic injustice. So I wanted to ask you whether you can add something about this, on maybe which instruments do we have in this respect. So I have a virtue ethical approach. So I was thinking about the role of virtue teaching, especially practical wisdom, but that's probably just my point on this. So I would like to ask you more, even if I know it's time for another talk, but thanks a lot if you can add just something.
Yeah, I mean, do you mean particularly in terms of character development?
Yes, I mean both, like instruments that we can give in hospitals to physicians in order, and healthcare professionals in general, in order to get rid during time of epistemic injustice, because it's a real problem, but also on instruments that we can use in developing our character that maybe can be related to the point.
Yeah. So, I mean, that's in a way the whole point of the project of EPIC. Is one of the four things we want to do is to develop tools for addressing epistemic injustice within healthcare. I don't know yet what these tools will look like. It's a 6-year project and we're only in our first year. But what I do think is that there will be something like a toolkit for patients. And again, I think phenomenology is going to end up being really useful here. Because a while ago, I developed a phenomenological toolkit for patients. And I'm now thinking whether that toolkit can actually be used, of course, for the patients themselves, but also as a tool for gaining our expertise in articulation, right? I mean, so sometimes people need to be helped in being able to articulate what they need and what they want, right? So, you know, I mean, we do that naturally with children. We say, oh, you have to stand up for yourself. You have to say clearly what you need. If the teacher isn't listening, you have to, you know, put your hand up again and say, so it will be something like a toolkit for patients, and it will also be, I think, in parallel, a toolkit for health professionals using the principles I outlined in the talk of how to, what an epistemically just health professional might be like. And then I think because healthcare is so complicated, I think there will also be a need to think a lot more in terms of, you know, the people who make the policies and make the decisions at the sort of higher level, maybe the level of what you would in the UK you would call the civil servants and the civil service and the politics, really. And then the broadest level would be the one of just engaging in general with the public and talking about, you know, a couple of things. I think talking about how we judge other people in communicative situations, the kind of epistemic judgments that we make about speakers, our ability to identify our own biases, implicit or explicit, and so on. So I think the addressing of the issue can be done again on a lot of different levels, and it will need to be sort of kind of work on multiple registers. And how exactly we do that, I think that's what we're going to pour a lot of our efforts into in the project. So please stay in touch, and I hope I'll have something good to share within a couple of years.
Thanks a lot.
Thank you.
Thank you, Elena. Thank you, Javi. We have some time still for more questions. I have some, but I don't want to abuse. So if anyone else wants to ask something, now it's the time. Okay. Well, then my turn. Okay, perfect. Thank you. I would like to ask you about the like the extent and the limits of epistemical justice. Okay, it was something that has been mentioned before in the questions and what you've been talking, because I think that there is one limitation which has to do with something that at some point Robson mentioned as non-verbal patients or dementia patients or people. I mean, because epistemic injustice is epistemic in its origin, so we are basing that on our ability to speak, yes, mostly. So what would be the challenges and strategies maybe to include groups that for one or other reasons are not heard? Is it possible? And on the other, let's say, end of this area of epistemic justice, up to what point the recognition of patients as epistemic agent has to be done? In a sense, would you consider public and patient involvement in areas of public health or research? Up to which extent? So how this testimonial knowledge, which is not scientific one, can, you know, be included in the social construct of knowledge, maybe research, policies. Thanks.
Those are great points. So first, about the nonverbal patients, there's actually a paper by my ex-PhD student who's now a postdoc in Oxford called Lucienne Spencer. And let me see if I can easily find the link. I was just looking at it the other day. Here we go. So I will post it here. So it's called Epistemic Injustice in Late-Stage Dementia, a Case for Nonverbal Testimonial Injustice. And it is, as I said, by Lucienne Spencer. So I haven't read it yet, so I can't tell you. But her work is really good. So first of all, what you're saying, I mean, there's a really big set of challenges that have to do with a whole, multiple groups of people. So again, I think children can also be pre-verbal. And people who have had strokes can often be nonverbal. Then we have people with profound learning disabilities, people, for example, with autism spectrum disorder, selectively mute people. There could people in severe depression or the severe depression side of bipolar. There will be a lot of really disparate groups where people just don't speak or can't speak. And I think that raises tremendous challenges to this idea that to be an epistemic agent, you need language. So you're absolutely right that that's a massive challenge. And I'll just mention also the work of Dan Degerman, who's a postdoc on the project and works on silence. And one of the things he works on is cases of elected silence. People choose not to speak. And what can we learn from silences of different kinds? So that's about the pre-verbal. I don't know if you have your own thoughts, Agatha, because you obviously asked the question. So maybe you have some thoughts.
I think I just have to question the problem myself here. So
Yes.
It's not about that. And I was wondering about, nonverbal strategies that could be, or there was that book, and it's the only strategy I can think of, which was called Unraveling. It is about autistic patients. And it's more, I will share that after. And it's about families. It's an ethnographic study with philosophical insight. He studies cases of two families with autistic children. So in one, there were he was verbal, the first one, but the only thing that really made him speak was Disney movies. So he would quote the dialogues. He would know every film. And the family engaged with him being in the Disney universe, so to say. And slowly they realized that first it had meanings. He started to using it more, freely, the quotes and the dialogues. And on the other hand, it seems that the patient himself learned how to express. So this process of like entering other environments, so to say, and designing strategies is the only way I can think of. But once again, that's individual in every case, and we will have like infinity of possibilities there. So, and sometimes not.
I know some of the tools that people use. So for example, people with strokes or with locked-in syndrome or with or nonverbal for whatever reason, there's really sophisticated not just keyboards, but also I think people can use this there's really remarkable technology that is being utilized to enable that communication. But we can also think about the non-verbal types of communication and whether we can commit epistemic injustices also in that domain, not by ignoring what somebody says, but ignoring, for example, their body language in certain situations. So that's I think that's potentially a really, really interesting area. Yeah.
Okay.
And your second question, I've completely forgotten. You said
about to what extent enable patients as what does it mean to be a carrier of knowledge, testimonial knowledge about the condition? To what extent would you see them as being part of social construction of knowledge or public policies and so on? So why is
okay? So yeah, so with this, I think now we're getting much better, for example, at synthesizing qualitative with quantitative data. So I think until not too long ago, people would say, well, yes, we have a lot of quantitative data, so we don't need the qualitative data because it's just anecdotal, or because it's you can't quantify it, so then it's not, we don't know how to work it into our decision making or policies, whatever. And I think what methodologically what you're pointing to is also very important, because it means we have to also, in order to be epistemically just, also enable a plurality of types of information that we are willing to accept. And
exactly.
I think, we can think of phenomenology as a really important kind of movement here, because phenomenology says there will always be things that the person, him or herself or themselves, can say, can know that nobody else can, the first person authority or something along those lines. So that's it's certainly important not to lose sight of that at the end of the day, the bottom line has to rest with the first person account in most cases. There will always be exceptions, but in most cases.
Okay.
Yeah.
Thank you. Do you have a time for one more question, or do I have to go?
Quickly, yes.
Andres, then.
Okay, thank you very much
Past privilege.
for this very interesting conference. I was thinking about epistemic justice. It seems to me that epistemic justice is related to building a common understanding, and also building probably a common language, which would also contribute to an hermeneutical justice. And of course, there are special conditions in healthcare that make it difficult to achieve this ideal about building a common language and building a very well understanding. Intersubjectivity is also an effective relation, and normally or oftenly in medical care, usually medical problems or medical problems in relationships are interpreted as a lack of empathy. And as you know, Hans-Georg Gadamer stressed the importance of conversation in healthcare and the idea of phronesis and medicine as an art and not just as a technical application. So I was thinking about what do you think about this importance of empathy and phronesis in the context of epistemic justice, or in the context of searching epistemic justice in healthcare?
Yeah, absolutely. I mean, the idea that it's medicine is both an art and a science, I think it runs very deep. And in a way, the epistemically just person will also be one who accepts that they don't have the first person authority, that has an element of epistemic humility in their exchanges with other people, and who remembers the Hippocratic Oath. I think the foundations of the therapeutic relationship are pretty unchanged, in the sense that it's it's an alliance between the patient and the health professional that is ultimately aimed to make things better for the patient. And it's not a symmetrical alliance. It's very much geared towards the patient's well-being. So I think you are right to point to the fact that it's both an art and a science. And again, especially if you take, for example, the big kind of neo-Kreplian movement within psychiatry, or this idea that we ought to try and emulate the same progress and successes we've had in somatic medicine, also in psychiatry, can blind us to the fact that at the end of the day, that human misery is subjective, and it's not just subjective, it is often caused by extra-medical factors, poverty, racism, government policies, and so on. So I think being very alert to that is exactly where where the art and the science can meet. I don't think one can come at the cost of the other. Certainly not. So in an ideal world, health professionals would also do a degree in philosophy and also study phenomenology and also do, maybe another degree in scientific methodology, and maybe do another degree thinking about rational choice and decision making, and also in psychology and so on. It's a very a lot of methodologies and disciplines feed into what we ultimately call, maybe slightly reductively, medicine. I think it's an incredibly rich domain. So thank you for raising that.
Thank you very much.
Thank you very much. Okay, so that's the time. The time has come. Thank you very much, Havi Carel, for your talk, for the discussion, for spending time with us. And I think that it was a great way of closing our seminar as well. So thank you, and applause, virtual one. And before you all go, we just want to remind you that if you wait 3 minutes, 5 minutes, something like that, we will launch, officially release the number of Estudios de Filosofía dedicated to the same topic, yes, disease, illness, and sickness. So those who you want, authors are welcomed. I can see you there. Yes, please stay with us, and we will be back in a second. Thank you
very much, Professor Havi Carel.
Thank you so much. I'm going to rush off, but good luck with the launch, and thank you again for inviting me. Thank you very much.
Thank you for
Thank you. Thank you.
Bye.